Good evening. My name is Joe Dietrick. I'm a CRNA in Chillicothe. Dr. Peniston and Ms. Klubine are in hospitals that I work at, and we're very fortunate to have them there. I've been a CRNA for 28 years, 16 years at Truman Medical Center in Kansas City as a CRNA instructor in an anesthesia care team setting, and the last 12 years in private practice in a rural setting. Our group provides sole CRNA coverage to 6 hospitals in North Missouri. We cover over 5% of Missouri counties. I'm going to get to, I think I can answer your question about collaborative practice. I believe I can answer your question about pain management. I'm going to talk to you about other situations. My concern with the need to pass this bill is that there is such a convoluted pathway to both the supervision issue and the prescriptive authority issue that we can't comply with them all the time, or we're at risk for adverse interpretation by a regulator and therefore can be cited or lose the possibility of obtaining some services. I would certainly challenge that I can provide safe anesthesia and have done so. I can tell you in our hospitals, our employees actually seek out the CRNAs to provide their anesthesia. I do know Dr. Perryman. About 30 years ago in my training, I rotated with her in my pediatric rotation and appreciated that very much. So to your question about supervision outside the operating room, there are situations where that's necessary. When we do labor pain analgesia, that's usually in the labor and delivery suite. There's physician not necessarily immediately there, the obstetrician. Sometimes we do radiological sedation and an MRI most specifically, and we may get called for critical services such as airway management or code blues in the in the ER or in the ICU. We don't have an operating practitioner in those. Now, a little history is the operating practitioner and supervision definition actually comes from CMS and Medicare, and then got codified in the statutes. So we're having to work backwards to undo this. We've got to get it out of the statutes before we can get it cleared by Medicare. Medicare defines what anesthesia is only in the hospital regulations. So we have to do this weaving thing to try to pretend that we're following all the regulations. Also, there are times in an emergency specific to the prescriptive authority when we can't have those signed in advance that B&DD has said is necessary. If we have an emergency C-section, they can't put those orders in. Or if in the middle of the night I'm doing a labor epidural, the obstetrician may have called in the order to admit the patient, which includes an order for the epidural to be placed on the patient request. If I need to give ephedrine, which is a controlled medication to support the blood pressure, I don't have an order in for that, and the nurse would have to wake up the physician to get that. Mind you, the controlled substance is very narrowly focused to the perioperative environment, to the drugs that we give every day, or in recovery room where I know what that patient received, how they responded, and what the best choice is. Not trying to expand practice in those cases. So for us, it's streamlining the convoluted processes to reduce the risk of adverse interpretations. And one of the other things in the CMS regulations that's relieving supervision would cause refers to podiatrists and dentists. The CMS regulations, unfortunately, are contradictory in their description of who can supervise. We actually had a state surveyor in Bethany last October, and thank goodness I was there because I know the regulations, who questioned whether we could do an anesthetic for a podiatry case because they weren't an MD or a DO. And I showed her where that is in the CMS regulations, but they're a little contradictory. So we need to clean these up so we can just continue essentially the practices that we're doing, but without risk of losing our licenses, being cited, or the hospitals losing their ability to do podiatry or dental cases, which all 6 of the hospitals we cover do one or the other. Thank you.
I have a question. So you're saying we need CMS revisions, that what we're doing is not going to have effect? I got a little lost on that.
I know, it's convoluted.
I mean, because we don't have any control over CMS. I wish we did. But
no, you don't. Except, so supervision is something that was going to be relieved entirely by CMS back in the year 2001 because of a 1998 article that showed we were just as safe. However, because of the push-pull, throw something against the wall, everything against the wall, something will stick, they came out and the states can opt out of the supervision regulation. But we have to get it out of statute before the governor can opt out of the supervision. And the description of supervision in the CMS guidelines is variable. If we're free of the supervision, then we don't have the issue providing any question about being able to provide anesthesia for dental or surgical cases. That also gets into the definition of what is anesthesia. Is a sedation case where I give a little bit of medication, actually an anesthetic? Is labor pain relief an anesthetic? Those are defined differently in different places, and those things become crystal clear and okay if we can get relief from the supervision guidelines. And then regarding the prescriptive authority, again, there are just times we can't comply in spite of best efforts for putting in an order set that I personally wrote for our institutions for the physician to sign for me to give. And to your question, if I may address the previously addressed questions, if that's okay. You asked about pain management. Back in 2014, a bill was passed that prevented CRNAs from using advanced imaging modalities such as CT scanning or real-time X-ray. So being able to place the spinal cord stimulator is not feasible. These orders only allow us to administer medications in the perioperative environment, so we can't send them home on a script for pain medicine. Ketamine clinic, okay, I don't know, maybe, but low-dose ketamine has actually been proven to be very helpful in a number of situations. But the type of pain management you're referring to, Representative Thomas, I don't see as feasible just because you can't use the imaging necessary, which was the entire intent of the bill in 2014. You had a question about the collaborative practice. That's where things got muddied years back when they wanted to give APRNs prescriptive authority and in a collaborative practice agreement, CRNAs were specifically carved out of being able to give those. I think the concern by the opposition was, okay, a CRNA could get collaborative practice agreement, use the prescriptive authority to do what we're asking to do going forward. Collaborative practice and supervision are not the same thing. Supervision is a definition that comes down from Medicare. Just means we have to work in the presence during an anesthetic of the MD, DO, podiatrist, or dentist. Again, you get into the definition of exactly what's anesthesia. So there's nobody I know uses collaborative practice in a nurse anesthesia environment. For us, it'd be impossible. We cover 6 hospitals. We have 5 full-time CRNAs, several part-time CRNAs. The math just wouldn't work in those situations anyway. And all we need to do is have the presence of the practitioner in the operating room. That part's not going to change. What's going to change is the regulatory risk from interpretation of these, our ability to navigate these little zigzags of the convoluted regulations, and making sure we're doing everything we can to be compliant.
Representative Stinnett.
So am I understanding that you're saying there's always a physician, podiatrist, or dentist throughout your administering of the anesthesia process? In
an anesthetic in the operating room, that's correct. Because they're the people that are only allowed by CMS to do surgery.
Okay. So there's never a point in time where you're with the patient and they aren't present either before they start the surgery or
immediately
during a portion.
Available is a common phrase, but we don't start a procedure until the surgeon's in the operating suite, so to speak, and they may be back out dictating, but they're going to come follow up on the patient. Again, we have a very cooperative environment with all our surgeons. We're very fortunate in that regard.
So a protocol change would not be sufficient enough to address the issue that you talked about where a physician was at home, you needed to start, say, an epidural. I'm not an anesthesiologist, so forgive me.
They cannot call in a controlled medication order set.
Okay.
And if the patient comes in the middle of the night and they haven't got on the computer, because they would only do this on somebody they've already seen in clinics. If there's what might call a walk-in, somebody from another town that they've never seen, they would come in and see that patient directly. But they would have to get on a computer to do an online order for those situations. And it's not one, I give ephedrine for a labor epidural and low blood pressure. It's a blood pressure medication probably once every 20 or 30 or 40 epidurals. It's not common. And again, it gets back to the stuff, this is what I do every day. Multiple times. And I'm the only one in advanced practice without prescriptive authority to any degree.
Sure. Okay, thanks.
Further questions? If not, thank you very much
Thank
for
you
your
very
testimony.
much.
Appreciate it.
Appreciate your time.